Welcome back. Thank you for your energy this afternoon. I know it's been a big day, and we're looking forward to having the report of your group interaction. What we'll do as far as our reporting is we'll work through, Nathan's got slides for the individuals, and we've got slides for the groups. So we'll report back group by group and then look at the aggregate of that. So Nathan, are you ready for the individual summary? Okay. Oh, okay. It's not on my screen. I got it. He separated me. So in terms of the numbers, the smaller numbers are the priority leading up to the larger numbers. So promoting these are your individual results, what you sent from your smartphones before you went to the groups or before you did the group consensus. So promoting lymphedema management, research for standards, and some groups ask that standards for protocols for measurement, care guidelines, improving reimbursement, number 3, number 4, enhancing patient education, number 5, awareness of lymphedema, number 6, health provider education, and number 7, credibility of ALFP. So could we go to the next one? Yes, so go back. That was the individual averages before you went to your groups. That's the means of those, yeah. Now let's go to the next one. So what else? These were added in addition to those topics. Best practice clinical protocols, measurement guidelines, which we know is kind of in that standards, but it wasn't clear. The data under that were those. Reimbursement coding, health policy, ALFP growth, funding, industry partnerships, and minimum data set predictive models. Those are all very great. And then what else? Continued. Fewer responses here. Those are numbers of responses. Continue reviews, patient interpretations, like the translation of those by patients. Patient education, research opportunities, the PCORI, provider education, awareness, community involvement, mobile health, and then no thoughts on 2. We were tired. I think that's that, the mobile applications. Yeah, taking it to the patient. Yeah. And then what else? Okay. Oh, feelings about research. This is interesting to us. Dr. Cormier and I and Kate will be interested in this. 12, when you ask, would you choose to be randomized? Would you choose to select your treatment, or it didn't really matter to you? 12 said they would prefer to choose their treatment. 11 preferred, it is. We'll send this on to PCORI right away. And I said to Nathan when he showed me this, I said, well, then our groups will be even. We don't have to oversample. They'll just split out just like they should. And then Nathan said, well, probably those are researchers and patients. But 3 don't have a preference, and they would do either one, apparently. So that's neat to get that feedback. Is that the last individual slide? Oh. Now, the group, these are the questions in coming back with your group. What did your group identify as the most important priority? What activity do you think ALFP should take on this new year? That's one question. What individual thoughts changed as a result of discussion? What else does your group want to share? So Tori is working right now on the data that was sent from the rooms, and we hope to show you that by group and aggregate while we're reporting out. But I'd like to give each group, now we have 6 groups instead of 8 because we collapsed. In more ways than one, we're getting tired, so we collapsed. So I'd like to just go through up the rows and have each group report out or come down. So maybe I'll start with Mr. Michael Cannon in the back for his group, because I think he's a reporter. For you, are you a reporter? And yeah. Would you like to tell us what your group identified as a priority? Do you want the microphone? I can bring it to you. Or
you have to go for the picture.
The cameraman's gone. Good.
Oh, you're on
No.
video.
All right, so you want me to just
do a summary if you want to look at those points there, but if you've got a summary ready, that's fine too.
Okay, that's fine. So what did your group identify as the most important priority? What activity do you think the ALP should take on this next year? So there were five options, so we prioritized those 5. Number 1 is research. Start with, first things first. 2, then set standards. 3, payment barriers, because unless there's payment, none of this may matter. 4, awareness and education, and then 5, then the actual treatment for the patient. So obviously people may have a different priority, but I think they all matter. I think they were all pretty close. Okay, you want me to go on to the second group? Yep. Second one, what individual thoughts changed as a result of this discussion? What else does your group want to share? Do you want me to read the statement here? Okay, so we believe the role of the ALFP would be to identify all U.S. lymphedema organizations and its contributory role of the ALFP to each organization.
How can we
Group 6!
We just really felt that was supposed to
Yeah. Sure, we can leave the note. Right. So at the end of the day, what we're saying is, why doesn't the ALFP, which kind of is already, just continue to take over a leadership role in the industry, help every organization that wants to be part of it identify its own niche, because everybody isn't necessarily sure how everybody fits in and what everybody is working on, whether or not it's different or people are overlapping. So it would be great, to see that continue to clear up a little bit.
That would be great. Now I've asked Michael if he will leave his notes with us so we can actually transcribe that. And I'll ask the other groups if we may have your notes, because we're not recording right now.
Can I email to you?
That'd be great if you have. That'd be great if you email them. That's fine, because I think our helpers are making slides right now, so they're not able to transcribe.
Right.
Thank you.
Sure.
Do you have questions for Group 6?
Someone took a picture of the child.
Group 6 was awesome.
Thank you. Can I add something real quick for Group 6? I don't think that we're thinking along the lines of importance, that patient treatment is less important than anything else.
Right.
I think we're more looking at what has to get done in order to get that patient treatment, which is the utmost goal.
Right.
But if
It's like
there's no
milestones.
funding,
Yeah.
the treatment's not going to be there, and if there's no research, the funding is not going to come.
Right.
So it's
Right.
not important.
Very much. Yeah.
Right.
So Group 6 should stand up maybe, so that everyone knows Group 6.
Come on, Group 6. And we had Paul Stewart, who had to leave, and then the gentleman, I saw his name, but I don't remember it. Calvin, yes. Calvin, whose wife is a patient. So the nice thing is we had a lot of diversity of opinions. So you might go around the room and everybody had a different opinion about what was most important at first. But then after we talked about it, everybody kind of agreed, regardless of what their connection to the industry was.
That's wonderful. There was a question for you, I think, Joe.
Yeah, we'd also talked about, in Group 5, we also talked about standards. We thought we should stay away from the term standards because we should promote evidence-based practice and so on. Standards has legal and licensing implications.
Right.
And we thought and I thought we should stay away from that term.
Maybe we should move to Group 5's report.
There you go. Come on, don't be shy. Come on.
Who's number 5? Someone was appointed.
We've got somebody in the back chewing.
Okay, where's your cell phone? Okay.
Oh, we don't need your cell phone, Joe, because Nathan's got that part. Yeah, we don't need the cell phone because Nathan's got that.
Oh, we had a picture. We have the
Oh, you have a
picture.
picture. Okay.
That's okay. No. Actually, it's okay. I will just do it, and then you guys. choose which side. Thank you. So I think Dr. Shi and Dr. Feldman just put me on the spot. They don't want me. Anyway, so our group had a very lively discussion, and I think we also have we motivate each other with the insights. So we think patient-centered care basically is in the center, and we think, we need to promote evidence-based practice, and we need to promote patient-centered research. And then our priority, we think, is a patient education.
Right.
Yeah, patient education.
Provider education.
Provider education, that's the first. And then we think about awareness. Awareness, we think maybe is two parts. One is the public awareness. How are we going to use media, publications to increase the public, and like average people who go into the airport, they know about it. And then another awareness, and basically is Medicare, Medicaid, and third-party insurance awareness. Because right now, 10 years ago and 15 years ago, the evidence is different. So what they reimburse, what they do is different now with all the systematic reviews out and with all those randomized clinical trials out. And then we need to find a way, collaborative way, concerted way to really give those evidence to the third party and at Medicare. That's what we think. And we also think like a cost like a range of costs, for example, treatment cost, training cost, equipment cost, and also like a utilities cost, and all of them are connected together. Did I miss anything?
No, you covered it.
Oh, I covered it. and then we think about basically if we put patient in the center, and then if we all go around that part, probably that's what this ALFP will do for the patient. I think I lost something, probably. I think
The other
that's
thing
one
we
part,
we also
one part
discussed
I cannot remember.
we also discussed the issue of overtreatment of patients.
Oh yes, or abuse of the system.
Abuse of the system, both by vendors and by therapists and even by patients who seem to have an insatiable demand for continued therapy. And that goes back to the education issue and so on. I strongly feel that there's a lot of money being wasted that probably is taking money away from people who really need it. And you've all experienced this by just overuse and abuse of the Medicare dower, the insurance dower, not just Medicare.
Right. And I do, we also talked about, probably, as a person or as a researcher, as a clinician, we probably do not have the power to really change the medical system. However, as an organization, American Cancer Society, ALFP, and Lima, and so if we really collaborated to collect all this evidence in the past 15 years, here is the trend, evidence-based practice, the reimbursed policies need to, like for example, patient education definitely can create a great clinical outcomes in terms of the symptom experience, functionality, but why patient education is not reimbursable? And then thinking about diabetes, they do get reimbursed for diabetes education. They do get reimbursement when you teach the patient to do the glucometer, right? But why we do not have money to reimburse for patient education? So that's we also discuss about that part too. Yeah.
I think that pretty well covered it.
Thank you.
Good job.
Okay. Then, actually, we had a very good discussion.
Thank you. Sounds like it was very productive. Thank you. Thank you. So we've got groups 6 and 5. What about the higher group number? Which one combined with 8?
3.
3 and 8. So could 3 and 8 go next? We'll work from that top down this time. Give room the floor. Thank you, Mike. If you want to do the notes.
I'll have to write them a little bit. I'll send them to you, I promise.
That'd be great.
We had a mixed group, of course. We had a couple of patients and patient advocates, and we had industry representatives and therapists who also were connected very closely with patients. And then I was there, so stuck in the middle, researchers. So we really struggled with the priorities. And just like with the very first part where we were supposed to identify those issues, all those issues were important, and you can make anything that you can think of fall under one of those issues. So we couldn't eliminate any of them. We didn't really think you could add anything because you could find a way to put it underneath. So our priorities were a lot different from the other groups because we maybe looked at it more as a patient side of it, and that's what's our group consensus. So our number one was to create the awareness, because patients were telling about other patients that were not even told they could get lymphedema from their physicians now. So awareness we thought was number one. And then because they weren't being told, health education of the health providers came in 2. And then patient education was 3. And then we went to establish the ALFP more, because we think it's working now. And then finally, the research for evidence-based management and reimbursement, because we figured those 2 would follow the awareness and the education. So it's a lot different than what the other priorities came up. And when we talked about what the ALFP should do in the future, we thought more of these groups, more of getting together stakeholders from all different areas of the field and trying to work on an agenda to move forward, and seeing they can be a little bit more of an advocate for that. We were a little bit torn on that, because we said even if the AMA said this is how you do it and this is what you need, people wouldn't listen to them. So we didn't know how we could increase the credibility of the ALFP to get to the AMA level, and even if it would make any difference. We had some further discussions on the emerging issues, probably because we were more patient-centric, again, was garments and reimbursements for garments and bandages and reimbursements for bandages, because those are issues that the patients were really having. And then maybe from the therapy side, what is going to be the impact of these future limitations on healthcare and the standardizations, right, and understanding Joe's point there, of course, and limitations on treatment of future to the therapist that can then offer their patients. Right.
Thank you. That's great. We made a new group. So now 7. Okay, good.
All right, so my teammates might have to help me out, because I would have taken better notes if I had known from the start that I was going to be the spokesperson, but I wasn't informed until the end that I was going to be the spokesperson. So we approached it from the perspective of what's going to be the most beneficial to the patient, because nothing matters if it doesn't eventually flow back to the patient and help them. So our first 3 priorities were identical to the last group. We agreed that awareness has to come first, because it's the foundation for everything else. With more awareness will come more funding, more education, more everything. Everything will flow down from more awareness. Number 2, we had as established criteria for health provider education, because again, if you can't even get diagnosed, if you don't know you have lymphedema, then nothing else matters, so we considered that second. Third, enhanced patient education, because once you're diagnosed, then you need to understand it and have as much education as possible. We had 4 as improved reimbursement, because once you know what you have and what you need, if you can't get it, again, you're not going to benefit from the treatment available. Number 5 for us was promote evidence-based lymphedema management. And we actually had established credibility of ALFP as 6, because we feel like that's been done. And it no longer needs to be a priority, because you have credibility, and by doing all these other things, it just further enhances the credibility. So it's not because we didn't feel it was important, but just because we feel like you have. And then in terms of our suggestions that kind of tied in with our priorities, along with creating awareness, was making the connection between lymphedema and obesity, more commonly known. In terms of enhancing patient education, that the ALFP website could be more patient-friendly, so that patients could more easily find the information that you have. And we also talked about this, I don't know, I guess this would kind of tie in with maybe patient education or even reimbursement, was that the eventual need someday for including more counseling and emotional support to patients that would really help with adherence to their treatment. And as therapists will often point out, they become not just the physical or occupational therapist, but kind of the emotional therapist, and having someone who's just there to help through that side of it would really be a huge benefit to patients eventually. Did I leave anything out?
The only thing I was thinking was the medical education, CME provisions.
Oh
and
yes,
things.
we talked about how could we make, lymphedema more known in the medical community, and the most practical suggestion was through continuing education courses, at least as our first round of trying to educate physicians more, is to not try to go straight to the AMA and get it in their initial med school training, but first work it in through continuing education courses.
Great.
Would you send us your notes?
Yes, I
Or
just
send
signed them.
That's fine, that's fine. And what I'll do is prompt the speakers to get the notes from their group. So if you need help from your group too, that's fine. Let's see, group 4. Linda, are you our spokesperson?
I think by default.
For those of you that haven't met Linda Cooperstock is the newest member of our team. We do this funny thing, we recruit volunteers and then we try to keep them forever. She came in January. She retired last April and she came to us in January. So we're very fortunate to have her.
And I'm at a slight disadvantage with all the acronyms, so I'm learning a whole new line. Anyway, I'm by default since I did a lot of typing. But we talked a lot about education and awareness being the basis of all the rest of it. And primarily educating physicians and the healthcare providers, because it was thought that if the physicians know and are aware of lymphedema, then they will be making the diagnosis or making the referral for some treatment. So that was primary on the list. We did talk about standards, and we had some discussions about what the definition actually was. So we were missing a little bit, excuse me, of the definition that included measurements. But we decided that if people aren't aware using the standards, then there's no, in other words, finding and agreeing on thresholds of where to refer from and that kind of thing. And also standards allow us to give foundational knowledge to the patient. Payment barriers came sort of next, although we had trouble agreeing on the numeric order after a certain point, because everything was very important, so it's hard to make everything on top of everything else. We felt that payment can influence compliance. So on one hand, if you have barriers to payments, perhaps patients aren't getting treatment. But then the point was made that there are some treatment options, payment treatment options. For example, Medicare seems to provide a fair amount of payment. And there are some donation types of options, but the indigent patient can't get into the system. So if you can't get into the system, then you're not getting into those options either. And insurance companies are a little more difficult, so Medicare was a little better than that. When we talked about what's missing, one of the items was access to care, treatment, diagnosis, et cetera, especially people in the rural setting. And we're seeing in some of the calls we're making now that patients are a little less willing to come in if there's no reimbursement for travel. So it seems like gasoline money is an issue. Some of the actions are get to the people who are providing treatment so that the patients can get onto the national registry. That would be a priority. We talked about the various LE groups. Are there too many? But the discussion was that they seem to serve different purposes, and not one group can handle all the aspects that are required. Each group seems to have its purpose. We like to think there is credibility now, agreeing with the one group who said it wasn't the highest priority, but still need to push on. Because it's mostly volunteer and most of the people have full-time jobs. And also as leaders retire or step down, there's a concern over who will run the organizations. in terms of continuing as an action on education, we agree with the continuing education units, and we suggested doing a series of briefer, like lunch hour webinars with CEUs offered, thinking that that might be a way to get busy people in, not having to have them travel to go to get their education. Exploring social media to spread the word about the educational opportunities and these kinds of conferences and the webinars. There was a suggestion to partner with all the accredited schools of CLT to establish awareness for the ALFP. What do we need? We need a big PCORI trial. And when publications come out of that, make sure that, or of any research, be sure the publications are accessible. I heard in our group that some of the publications that the articles are in are not in PubMed. So that makes it a little easier to get to. Medical schools don't seem to be jumping to add LE to the curriculum because it is time consuming for the curriculum. And we need to educate some of the other specialties. There are some specialties who get it, and then some specialties who need a little more help. Did I miss anything?
Very good, very thorough. Good job. Oh, thank you. Look at that. You'll have to work hard to beat that. She's already said it. Now groups 1 and 2 were combined?
No. One was separate from 2.
Okay. So 1? Are you 1? Thank you for correcting that. I got kind of puzzled by our groups at the end.
Figure out where to put this.
You could stand
So it doesn't knock down.
Do you want to be right here? Because we're not using
Okay, our group was diverse. We had occupational, physical therapists, nurse practitioners, patient advocate. And we actually sort of diverted from what some of the groups did. We didn't want a number 1 through 6 because we felt very strongly that awareness, patient and provider education were really number 1. So we just kind of put them across the top and did some in-depth talking about that. Talking about provider education, certainly the physician-intensive model is a great idea. Joan was talking about her recent conference where they had 20 physicians for an evening. Someone pointed out that in terms of acute hospital, often it's the nurse practitioner or physician assistant is the person that will be working with the individual. So that's a group that perhaps we should really market to in terms of short, even if they would be hour, 2 or 3 hour evening presentations. I like the idea of maybe hour-long lunch webinars, 2 or 3 to give information. That's really a great idea. We did talk about standards in terms of measurement, and that this is the talk that keeps going round and round, and how to get everyone to agree on one standard of measurement. And certainly there are methods that are used in research that necessarily, I feel as a practitioner, that I could not spend the amount of time when I'm seeing maybe 3 checkups in an hour-long time when I'm doing follow-up, so that I think we need to find something that the busy clinician that most likely is using a tape measure, if they don't have a parameter or they don't have bioimpedance, needs to have a method that's doable every time they see their patient or want to assess them, so that it's not something that if you have a half an hour to spend just doing measurement, but that's not always realistic in the clinical setting. So I guess that's my own personal plea for that. My suggestion was perhaps it could be something as simple as the European model for custom compression stockings and garments, which we all are familiar with, and that measurement system is used worldwide, and there are definitive points that are used, and I think that that's something that probably everyone, regardless of whether they measure over 10, every 4 centimeters, is utilizing and has used. And so perhaps that's something that we, and certainly for industry and in the data that they have, they're using that as well in their measurements. So maybe that's some way that perhaps we could all come to a consensus both in here and internationally, because everyone is using those measurement systems if they at all measure for custom garments. more work on risk reduction, education, and early intervention. That was something that we thought was really important in terms of research and identifying the effect of doing early intervention and risk reduction education over time. We did identify the issues of reimbursement and how difficult that is for patient adherence. It may be that someone's limb volume has gone up, they come back, and maybe they're back a year later and they couldn't afford to buy a compression garment within that year. Maybe they needed one at 6 months and couldn't afford. So it isn't that it was through their own not following the recommendations, but that they couldn't afford something. So that often is a big issue in terms of reimbursement. Also for prospective surveillance and follow-up. Sometimes follow-up visits are not necessarily reimbursed. And so that's an issue that I think needs to be addressed. And the other thing, we also did feel that the ALFP does have good recognition, and we thought that perhaps a new role or one new role for the organization might be what some other people also suggested, to explore collaboration and coordination among the many different lymphedema organizations, whether that would be an umbrella type of a situation or some other kind of a situation. But I certainly think that the organization is poised to perhaps do something like that. And there are so many of us that are involved in a number of the organizations anyway, so that perhaps things that are duplicated would not be necessarily duplicated, and other things that could be done that perhaps each individual organization is not able to do because they don't have the funding or just the man and woman power and time to do, perhaps could be done. So that's about it. I don't think I left anything out. Did I, Joan? No? Okay.
Good report. Thank you. Thank you very much. So we have group 2 to come forward? Or did 2 get 2? Thank you. You were the appointed person.
Yeah, I don't know if I was appointed, but I'm here, so I'm probably going to need help.
You're anointed too.
Okay, so we spent a lot of time, I guess, kind of going over the priority issues and barriers, and it was an interesting discussion. I think helped in the second part. So we basically, most people agreed that awareness and education was a top priority. And then we talked about standards and training, and then it's kind of like, there's almost a logical flow, which could be, well, you have to have awareness and education before you can do treatment. You have to have treatment before you can come up with a standard, and then you could argue about which comes first, research or standards, and then payment barriers. But I guess we ended up awareness and education, number 1, standards and training, number 2, treatment, number 3, research, number 4, and payment barriers, number 5. And so then we went on to prioritize the identified actions. And I think we all, and this kind of leads, I guess, into the strategic plan, where we really felt like the criteria for health provider education was a really important component where we really probably need to focus the most. And we had a long discussion about where this comes into play, at least for physicians. There's really just not time in medical school curriculum. I mean, they have a lot of things you have to follow. You spend basically 2 years where you're in the classroom hitting the books harder than you ever have in your life. And then you got the next 2 years, you're kind of thrown into the mix, into the clinics. And realistically, I think, an hour education on lymphatics, which is what I had, which is all anatomy class, was probably all you're realistically going to fit in. There are so many priorities. I mean, we only spent a semester on pharmacology. If you look at all the medicine interactions and problems that causes, and there's so many needs. There's so much to know. The information is so vast. But it kind of fed in. Well, maybe the best place would be residency. And if you had to pick the top ones, then certainly the oncology group would be the number 1. If we had to target one area for education, it would be oncology, and then would be maybe surgical oncology. And along with that, you could go into radiation oncologists. And then on the nursing side, it'd be breast care centers or breast care nurses that specialize in that area, oncology nurses, radiation oncology nurses, and these kind of areas. And then it's also very important, like internal medicine or family practice. It's so big. It's not as focused a group. So I really think setting out on the others and maybe coming up with 4 hours of CME, we felt like that would be really important. Other things. Besides that would be creating awareness of lymphedema and lymphatic disorders. Most people had that rated near the top. And then we had rated around 2, most people, enhanced patient education, and that was felt to also be very important and can kind of go hand in hand, maybe at the breast care centers or at the oncologist. As part of your treatment, we need to have some kind of basic patient education too. And then promoting some kind of evidence-based lymphedema management standards, also being important. Some people felt that was the most important. Other people felt that kind of came second. And you could say, well, we have to have a standard. You know, is it going to be 200 milliliters volume change, or is it going to be 2 centimeters circumference? And so I don't know. Maybe you should pick one, but maybe, you know, either way you've got lymphedema. So, you know, at the same point, we've got to get people into treatment. So it's kind of hard to know. I mean, these things are important, and maybe having one standard would make it less ambiguous, but at the same time, there's such a need for training and getting people plugged in right. You know, how many doctors know what a stimmer sign is? You know, it wouldn't take 10 minutes to teach them that. But unfortunately, you probably need to pinch one and pinch a couple normal ones to really understand and see it. So I guess we felt that all these things were important. Am I missing anything here? What else?
I think you pretty well covered it.
Okay.
I think we talked too about the fact that we look at what the ALFP we'd like to see happen in the next couple of years is we're looking at the best practices as being the source for all the disciplines when it comes to the certification and the training at all the various levels with the therapists, the nurses, the physicians, the patients. We need to have a unified single source with the best practices and standards that we're all operating off of so we can have that consistency that we need throughout. And that's why, at least I think the group was making the point that that's one of the priorities we see for the ALFP.
Yeah, I see us, you know, worried about this minimum data set and, you know, kind of coming at this from, you know, wanting to establish better research and establish better standards. And maybe at the same time, you know, and we kind of have the therapist side, you know, covered through LANA, at least what, you know, you got to get the PTs won't always be in agreement that you have to go through this to do treatment. But, you know, we've made a lot of progress there saying, well, these are the standards that therapists need. But what I think is a glaring, you know, missing component is just the basic doctors. You know, they don't have 2 weeks to go to class. There's really not that much money in lymphedema if you're a doctor. I mean, you know, it's kind of like your job. It really is to triage it, know what it is when you see it, and get them triaged appropriately. And that's okay. I think we could have a good healthcare system. It'd still be a lot better. But what we really need to do is get some basic education. You know, is it 2 hours or 4 hours of CME? I don't think it needs to be 24 hours. It needs to be something more realistic, and then really push that. And I would really like to see. I think that would be one of the most important things that the ALFP could do in the next couple of years.
Well, like any kind of practice in medicine, if you're treating lymphedema, you can charge for a consultation, you can charge for an office visit. You're not making as much as surgeons do.
Yeah, but then you have to know who to go to because, you know, the oncologist is already kind of busy. So that's the other question is who is a lymphedema specialist? You know,
right.
And
that I think is part
and that's part of the problem.
Yes, you know, I mean, I tried to get into the local med school at my New York, SUNY, New York Albany Med, which is the capital of New York State, and I asked for 1 hour with the med students to just let them know there are specialists out there that do this work, you know, and they couldn't do it. There's too much. You know, their reasoning was there's just too much to learn, not enough time, not as important, maybe, I'm not sure.
Yeah, because I mean, we have a few people who do full-time lymphedema. We have a lot of physiatrists, and one wound care person. You'll see it in different places. It's kind of interesting. We don't really have oncology. I guess we have an oncological surgeon, of course, too.
This is just a baby step, but I had talked years ago with our pediatrician about how I could help educate pediatricians, and one of his suggestion was the continuing education courses, but an even easier, maybe something we could do even sooner than that, is he said putting together a good quality educational video, arranging for a viewing in your city, and bring in lunch for them. So just come over, have lunch, and watch our video. Maybe one person there to answer questions afterwards. It's a start. It's not the perfect solution.
Even if you didn't get CME approval, just to come up with a couple videos.
Right.
You know, okay, here's a 1 hour video if you don't have more time, or break it into segments. Here's 10 minutes, 15 minutes,
yeah.
And then here's a 4 hour module, you know, and we'll send you a certification, or, you know, the completion, you know, a certificate of some sort. And then, you know, if you can get CMEs, it couldn't be that hard with all our universities. I mean, I think there would be a tremendous opportunity that wouldn't cost that much.
Already, physicians are flooded with email that comes, and these are problems.
Yeah.
It has CME with it. You turn on the video and look at it and make your diagnosis and see where you were wrong or right and do that. But there are avenues for that kind of thing.
Yeah, it's not hard to do. Yeah, the biggest problem is that you get inundated with them. And how many of them are there in your busy practice that you need to look at? I mean, I come across all sorts of ones that would be helpful and beneficial. You could just get into lymphedema. You could get a couple hours in there to really understand and see that. I see that in the wound care center all the time. It's a big workup.
Even if they just understand enough to make a referral.
Yeah.
Just to point you in the right direction. Start some cases.
Yeah, seriously, even if you had 30 minutes, this is it. Here's a stimmer sign. Here's a couple things we know.
Yeah.
And it's not enough, but it's a start in the right direction.
Thank you so much for your great work by each of our groups. I think we've all been stimulated by these ideas. We're going to see if Nathan's ready to put up. These are the means from the groups now. You saw the means from our individuals, so it'll actually be interesting when we can step back to see if they've shifted while we've been able to discuss our different perspectives. I want to give you some closure here, and we'll kind of digest this a little bit more. We'll put it at the website as a summary when we've had a chance to look at it and make thoughtful statements about it. So these are all twos, which would mean they're fairly similar in value now at this point, isn't it? Because they're means of 2 across our groups, and these were the ones that we provided with some refinement now. So create awareness, develop research to refine diagnostic standards, evidence-based treatment, establish criteria for health provider education, evidence-based lymphedema management, enhance patient education, establish the credibility of the ALFP, improve reimbursement. So they all are important from the group consensus.
Mm-hmm.
Nathan, do you have another slide of what we should accomplish?
Yes.
Promote evidence-based lymphedema management through support of credible research, work toward evidence-based studies, and the PCORI grants.
Mm-hmm.
Spreading the word, keep pushing awareness and standardization, continuing holding meetings and stakeholder consensus. About lymphedema, define lymphedema, nature of lymphedema as a disease, better understanding, home program components, see patients do awesome in clinic setting and then fail at home. It's a big issue, isn't it? An umbrella organization, identify all U.S. lymphedema organizations and contributory role of ALFP to each unique organization needs to be communicated. Become the umbrella to oversee the variety of other LE organizations in existence to improve collaboration. Best practice, create best practice model for all professions and patients. Finish best practice in using all fields to establish certification training in each field so that everyone is going back to the same source. So this was from that one discussion about all professions. Create, okay, is that the final? Continue education units, continue medical education, webinars and assessment tools, best practice documents, minimum data set, align with accredited organizations, establish firm recommendation for education of providers.
Yes.
Facilitate discussion between lymphedema schools to strive towards standardization of measurement tools, garment measurement tools, outcome measurement tools. Very good. More exposure with oncology, nursing, and medical students in their training and curriculum. Encourage institutions to support healthcare professionals to receive adequate training for treatment. And then how would you like to participate in a health-related study? So 2 randomization and 4 pick therapy. So this represents 6 groups. Whoops. Okay. Now we're in our email. So Tori did these for us. I'm sorry, I said that Nathan was working on this. Tori did the group ones. New priorities, training the therapist, differentiate between standards, and individualized care.
I forgot that slide, sorry.
Oh, that's okay. Thank you. Thank you. So new priorities here. Therapists, standards, and individualized care. Is that the final then, Tori? Okay, thank you. Dr. Terry.
There's a little conflict between individualized care and standard.
Yeah.
There is, isn't there? It's quite a balance there. Yeah.
So that becomes from a funding source, from allowing the program to exist in a facility. There are all sorts of things which tend to hurt the patient because he'll be an outlier rather than everyone's the same.
Mm-hmm. Right.
Evidence-based practice.
I agree. But I
Yes, Catherine.
I do think it's important for myself, I can share that there's some basis of standardization and then our expertise. When we teach CDT, we teach it in a way of this is the basic recipe. You're not going to be able to treat all patients like this, but if you don't have some sort of foundation, then everyone is just all over the place. You have a basis, yes, and this is the basis. And as we gain experience and become, better, we can then individualize.
It's the best practice, it's not a standard.
Yeah. Right.
Michael, yeah.
Well, our group struggled with that same thing too.
Yeah.
And what we determined, or one way we figured it out, is that we can't make standards until we've classified the patients into small enough groups. So somebody comes in with stage 1 lymphedema and may have this standard, someone with stage 2 would have this standard, someone with stage 3 would have this standard. And then if you had obesity with stage 3, that's another standard.
Mm-hmm.
So don't look at it as one standard
Yeah.
to treat everybody, but look at it as a collection of
Yeah.
standards for each individual classification of patients.
I might give you an example there. Dorit has gone to bed in Israel, but she was with us until noon. But she reported to us last week when she was here that they start out with 4 codes on lymphedema in their Israeli data set for their HMO. They now have 60 codes because they wanted to differentiate the stage and the actual treatment. Not like CDT as a single code, but the components of that, as well as the individualization of a patient. So they're piloting that now in their HMO, their certification database for the reimbursement. Yes, Tammy?
There's so many patients that doctors, and maybe it's education of the doctors, we're referred to so many patients that don't have true lymphedema, but we're treating lots of edemas out there. And that care, they may not need all the other components.
Yes.
But yet it's all, it's all the basic, but we may not do all the other stuff. So
Yes.
if you have one standard, you may look like a really bad therapist, but you're actually a really good therapist because you're treating based on what that person needs.
Correct.
When I think about it in the palliative care setting, the nursing homes would it would look as if they weren't caring well for a patient in palliative care if the patient lost weight. Well, the patient in a palliative care stage will be poorly nourished sometimes and will lose weight. So we do definitely have to individualize the standards, the Medicare reimbursement standards to that patient and to what was needed by that patient and how well it was delivered, I think.
And the geriatric population is very different than what we would do for a younger person as well.
The other thing we need better ICD codes. Because we're stuck with 3 codes, 757 congenital, and breast surgery, post-mastectomy, and then everything else is lymphedema other. So lymphedema, there's nothing for lymphedema, there's nothing for other things we deal with. And there's a mechanism for doing that through the AMA and going to committees.
You can code lymphedema though. I have a diagnosis for it. It doesn't say lymphedema, but something.
Isn't it limb swelling or something?
I forgot what it
limb
is.
swelling I use, but that's not.
No, this is like a disorder, like adipose
sort of metabolism
disorder.
or something.
Yeah, something like that. Yeah.
And that's in the process of getting a code for lymphedema too.
Who's in the process?
Karen Herbst has been working with the
I'm
the
sure
government
ICD-10 has
yes,
one.
to put an ICD-10 code for lymphedema.
Dr. Terry?
Yeah, I'll email that.
Well, the process for getting codes is to go through the RUC committee. Hey, you might, with this organization, be able to state something to the RUC committee who sits down and decides what that will be. And then there's the ICD-10, which is 10,000 rather than 1,000 diagnosis codes. You'll have codes coming out your ear. Did this lymphedema occur in the bathroom or on the road? But the RUC committee residency, well, I'm not sure what the RUC is, but that's who decides it. It's under the, not under the AMA exactly, but it's the RUC committee.
Very good, thank you. We are very close to the end of this wonderful time together. I don't even want to let you go. I want to keep you for another day, for a beautiful spring day in Missouri. But I so thank you for your time, and we appreciate the wisdom that you bring, the energy, and the sharing that you're willing to do in this room, and we look forward to the next time together. Hopefully we'll be back together someday in Columbia again, but the nearest time we have scheduled is October 24th in Atlanta, the day before the Lymphedema Network meeting, the Lighthouse Lymphedema meeting on the 25th. So we're trying to take advantage of people traveling to that location. We've proposed in our proposal various other sites, and we welcome input on where other sites would be. We'd like to have kind of a rotation of coming through sites in the Midwest and in the North and the South and the East and the West. And so if you know of an institution, for example, that would like to host us to come, that would be marvelous. And if we have the capability to do a streaming like we did today, with going to Israel and South Africa, and we offered it throughout the state of Missouri through our telemedicine network. I don't know how many sites signed on today, but now it's archived, and so those wonderful lectures that you heard, we will be able to make available to other people that couldn't physically travel to be here. So that's one of our goals, is really to get the information out there, to put that source at our website, and to continue to build these partnerships that we have with all of you in this room and the people that couldn't make it today but would like to be a part of the Stakeholder ALFP group. Are there any questions before we release you to the world outside? I just thank you so much. I do want to announce that those that came on a shuttle from the hotel will meet at the bottom of these stairs out here if they came from a university shuttle. And the steering committee, I'm going to hold together for a little bit longer. We have a meeting this evening to process some of what we've discussed. So I wish I could have all of you with us, but we all need to process as we move home and share with us any thoughts that come to you as you do go back to your practice settings and to your homes. We always want your input. Again, thank you very much. We'll see you again in DC or in Atlanta or in Columbia or one of our meetings. Thank you very much.